Hi, my name is Julie Holland. I am a psychiatrist in New York City. I am the editor of the Pot Book. I used to run the psychiatric emergency room at Bellevue Hospital for about 9 years, every Saturday night, Sunday night, and then I wrote a memoir called Weekends at Bellevue. So I'm particularly interested in the impact of our drug laws on psychiatric patients and healthcare in general. And I would like to introduce the other people here. To my right is June Kim, who is a doctoral candidate at Columbia University and the Department of Epidemiology, who will be speaking, among other things, of the impact of medical marijuana laws on opioids detected among drivers fatally injured. And to his right is Angela Hawken, who is a professor of public policy at Pepperdine University, who will be speaking about, among other things, the impact of legalization of cannabis and other drug use among the criminally involved. And to her right is Rosie Pacula, or is it Pacula? Pacula, I was right the first time. Who is vice president of the International Society for the Study of Drug Policy, who will be speaking about whether medical marijuana laws reduce addictions and deaths related to opiate painkillers. So I think we're just going to go, each person is going to get around 15, maybe even 20 minutes to speak each. I will be occasionally asking questions. We will open it up to more Q&A after, but if you have a question during, you can text and it may find its way into the conversation. Yeah, there we go. I go first.
Hello, everyone, and thank you very much. I think it's really important, and we've heard this discussion during the conference at different points, that the discussion of legalization of marijuana in terms of its potential benefits and potential harm, positive benefits and negative consequences, the context of that conversation can't take place in isolation. There's other substances that cannabis is often used with or instead of. And so if you're going to have an honest conversation about the potential benefits or harms of legalization, you need to consider the implications of the use of other substances that might change in relationship to the policy. As ISSDP set out a request for studies on all substances, and it just so happened we got quite a few on opioids, which is what this panel is going to be talking about. Opioid abuse is clearly a very significant problem here in the United States. It's now labeled by the Center for Disease Control as a major epidemic because over 40,000 individuals are dying each year from prescription opioid painkillers. Nearly 2 million are dependent, and as of 2009, as this chart shows on the bottom, the years, the solid blue line is drug-related overdose deaths. Since 2009, drug-related deaths have surpassed those of both firearms, which is the dashed line, and the dotted line is motor vehicle traffics for unintentional mortality. So it is a major concern here in the United States. Drug-related deaths is being driven, of course, by the overdoses from opioid-related prescriptions, as is shown here, because drug deaths in general would include alcohol and other substances, but as shown here, it's actually this increase is being driven by opioid-related prescription. There was a study a little less than 2 years ago that came out that demonstrated that medical marijuana laws seem to have improved the situation with opioids, and that overdose mortality rates in states that had adopted medical marijuana policies actually showed a reduction in the rate of increase of opioid-related mortality vis-a-vis states that did not have these policies. It was a very provocative study, got a lot of significant attention, published in a very well-respected journal. But there were some limitations to the study, one of which was that they only looked at medical marijuana laws as a homogeneous policy, and they didn't consider the differential policies that were being adopted across states. They ignored, to some extent, they're using their methods, the differences across states that already existed in trends for opioid-related mortality, which then raises the question of whether or not there might be some confounding of, other unobservable factors and the adoption of these state policies. And then third, they only looked at opioid-related mortality. So a group of us that ran, my colleagues, David Powell and Murray Jacobson and I, decided we wanted to reconsider this and try to address some of the limitations of the studies and see if we could actually get at a similar result or if the result went away. We looked at things broader than opioid-related mortality. We also look at opioid treatment admissions and general self-reported non-medical use of opioids. And we paid attention to the alternative ways of modeling to account for these differences in pre-policy trends, something I'll show you in just a moment. And the main takeaways from our analysis is just predominantly the results of the previous study hold, although what's interesting is our analysis is it's not driven by states with any medical marijuana law. It's actually driven by states that have legally protected and active dispensaries. So where supply of these medical marijuana is made available, that's where we're seeing a reduction in the rate of growth in the opioid-related mortalities. We look a little bit at the mechanisms. And the mechanism seems to be driven both by potentially patient behavior as well as recreational misuse of opioids. So let me provide you a little information about how we got to these results. We looked at data on opioid use from a variety of sources. First, the National Vital Statistics studies, which provides information at the state level on all opioid-related mortality. We focused on the opioids that are of high level of abuse in the country. We use this, adjust it for age the same way the previous study did. So this was basically their data, but with a couple more years of information. We also consider admission to treatment for opioid-related addictions. So there's the treatment episode data set, which provides information at the state level. Any publicly funded treatment facility has to provide information on the number of admissions for various forms of addiction to the SAMHSA, the government agency, and we can identify people who are coming in for a prescription drug opioid addiction versus a heroin addiction versus a cocaine addiction. And we, again, targeted on the same prescription drugs that were being absorbed in our mortality data. And then finally, we looked at state aggregated data from the National Survey on Drug Use or Health. This is self-reported non-medical use of prescription opioids. In addition to these sources, we were interested in understanding, to the extent that we were finding an effect in the mortality data, did we see a similar reduction in the amount of opioids that get distributed for true medical purposes? The DEA has a data system, ARCOS, it's required for any pharmaceutical company or any company that touches a controlled substance to report the processing of and development of the pill, whether it was done in the US or outside the US, where it's distributed to, and all the way to the point of the retailer, whether it was delivered to a hospital, a pharmacy, and whatnot. So this is the DEA ARCOS system. From the system, we can look at every single controlled substance. We can look at all of the opioid painkillers that are tied to mortality, which we do, and construct a state-level estimate of the number of grams, which we translate into morphine equivalents so that we have a synonymous measure across the different opioids within the state. So those are our different ways of measuring the opioid-related problem. We look and compare how these look across states over time vis-a-vis state adoption of these medical marijuana policies, which we have been developing for quite some time and have used in other work. In our analysis, we control for other state-level factors, in particular, the aspects of the medical marijuana policies that we're interested in is availability of medical marijuana for medicinal purposes, so our interest in dispensaries, whether they're legally protected or actually active and open, were our primary interests. We control in our analysis a number of also relevant state-level factors, demographics that we tied to opioid-related abuse, as well as state policies trying to limit the problem of opioid abuse through state prescription drug monitoring programs. What I show here is the rise in our substance abuse treatment admissions for painkiller medications that we're using in our analysis. The graph is such that the year 2000 is everything's normalized to 2000. The blue line is opioid-related treatment admissions, where this is the primary purpose of the treatment admission. Also shown on this graph in red, can't be seen very well because it's overlapping with the green, are marijuana treatment emissions, which are actually growing during this time period. If you look at another graph where opioids weren't on, you'd actually see a nice big increase, but relative to the increase in opioids, it's substantially smaller, and the green is all treatment admissions. Now, I mentioned this difference in these pre-state differences in policies, pre-policy trends, state trends. What I show here, the blue line here, is all states that did not adopt a medical marijuana policy. What was their trend in opioid-related treatment admissions, opioid-related treatment admissions over time? You see that there was indeed a modest increase. The line above it in yellow, Maine, was a very late adopting state for medical marijuana, so looked a lot like the other non-adopting states until 2009, which is why the trend looks pretty consistent. The two lower states shown here, California and New Mexico, were kind of, I said Maine was 2009, excuse me, Maine's 2011. The two early adopting states actually have a flatter profile in their rate of opioid use prior to adopting the state policy. This is the differences in pre-state trends in mortality that we were concerned about in the previous study. So we use an estimation strategy that accounts for this, doesn't change the result. The empirical strategy is to basically take advantage of the differential timing in the state medical marijuana policies, not just any policy, but the adoption and opening of dispensaries, to identify whether these differential changes in opening affects the trends across states. We do a variety of robustness checks to check whether or not correction for these pre-policy trends through cohort synthetic control group analysis can account for this finding. It doesn't go away. We also do some event study analysis to see if the timing, if some of this trend was being picked up before the policy was adopted for concerns of policy endogeneity. Is robust to all of that. I'm unfortunately going to be running out of time here, so I'm going to show very quickly. What you're looking at here are the results of our study for treatment admissions. In the first column is where we assume we're going to evaluate the impact of any medical marijuana law, MML, first in the top row. The second row is identifying in the first two columns legally protected dispensaries. That doesn't mean that they're necessarily open. It's when the law legally protected dispensaries. In some states, there were dispensaries open before that. In other states, it took 2 years before dispensaries were actually open after the law passed. We're seeing a moderate effect, but it's not statistically significant. When you then account for dispensaries that are both legally protected and actively open, we get a significant impact on treatment admissions, and the combined estimate is about 43% reduction in treatment admissions. This is just another look at the data using one of our sensitivity checks. What it shows on the left-hand side is the findings, again, for any medical marijuana law. You can see there's no effect of the policy up to the point where it's adopted. In year 0 is the first full year in which the law was actually active. So for states that implemented a policy mid-year, -1 could have a little bit of a policy effect. Here you see no effect on medical marijuana laws until 3 years out. If you look at legal dispensaries, you're seeing no impact, no relationship between these states and treatment admissions prior to passage of the law, but as the time goes on, we're getting a negative and statistically significant effect on legal dispensaries. The concern about these differences in pre-policy trends beforehand can be addressed with the synthetic cohort analysis. I'm showing you the findings from one state where we find a state where we can match the outcome before the policy was adopted, mirror California in this case, and you can see California, the actual trend is in blue. We have a composite of other states that look like California prior to the adoption of the policy, and evaluate what happens to these two trends after California adopted its active dispensaries. And you can see very clearly California deviates from a synthetic comparison group that it was pretty closely mirroring before the policy, deviates substantially. Mortality data is basically showing the same effects. Because I'm almost out of time, I'm going to fly through the mortality. But again, here's the synthetic cohort estimate for a single state, showing that it's a little hard. Mortality data is a rare event, so it's really, really hard to know if findings on a rare event are a function of actual results or possible outliers. The fact that we're seeing similar findings in treatment is reassuring. In the case of Arizona, we don't do a good job matching the pre-trend because of a longer period, but we still see a pretty big difference after the policy is adopted. There's two potential mechanisms. One is that this is recreational users using for fun, and those are still people who could be abusing opioids and saving their lives. That matters, but the policy implications of whether this is a recreational user versus a medical user is entirely different. So we wanted to look at the potential mechanism. Non-medical use, as self-reported in the National Survey on Drug Use or Health, also seem to be substantially and statistically significantly associated with individuals who lived in states where both medical marijuana laws exist. There's not much of effect, but where the dispensaries exist and are legally active, we see a reduction in the self-reported misuse of opioids, suggesting that non-patient users benefit from the access to legal dispensaries. What about the distribution of opioids to patients? Now, some of this can get diverted from patients to recreational users, but we don't know that it's not just also helping patients from becoming addicted to opioids. What we find here is, again, not much of effect necessarily of legal drugs until we put in controls for prescription drug monitoring programs. Then we start to see that there is a statistically significant effect of individual policies, although jointly they don't matter. When we look at legally protected and active dispensaries, we get similar findings. What's interesting is jointly, they aren't statistically significant. So it's not having as much of an impact on the distribution of opioids in the medical system, but it is having a larger effect on non-medical use of opioids. So overall conclusions and policy implications is that these laws do seem to be effective at influencing opioid-related mortality, opioid treatment, opioid use. The fact that we're seeing it beyond mortality is reassuring that it's not just a function of perhaps use of opioids with benzodiazepine before marijuana became available, because benzodiazepine is contributing to the mortality rate from opioids alone. A lot of people who would be using benzos to help with sleep issues might switch to marijuana as an alternative. Marijuana and opioids then might be reducing the opioid-related mortality, but not necessarily abuse, if that was the full story, and our data don't suggest that. I think I'm out of time, so I'm going to stop there and let the next.
I just have one question. I was wondering if you could talk briefly about whether having an indication for chronic pain. For instance, New York State does not have chronic pain as a qualifying condition for the medicinal cannabis program. Do you have a sense that adding chronic pain as an indicator, as a qualifying diagnosis, would bring these numbers down even more?
So in the data that we have, most of the states actually include pain, chronic pain, as one of the indications. So by itself, I can't differentiate an effect of that diagnosis vis-a-vis any medical marijuana law. So unfortunately, I can't answer it from the data that I have.
So none of the states you looked at didn't have chronic pain as an indicator. Is that what you're saying?
Yeah, there was a high degree of overlap in the early adopting states that had pain as one of the chronic conditions. And so I wouldn't be able to differentiate the effect of any medical marijuana law from a state that a state that passed the law but didn't allow chronic pain.
Okay. Well, let's see who's next based on the slide that comes up next, and we'll decide who's going to speak. Survey says. Next slide, please. Well, I'm going to take this moment to do a little plug, because I forgot to say something in the beginning. There you are. All right, Angela Hawken is speaking next, and I will save my plug for later.
Thank you. I got the short straw. So the original title of this was kind of dreary, if you pay attention to it. It was Marijuana Use in a Criminal Justice-Involved Population Under State-Level Legalization, which doesn't do this research any justice because it's actually kind of cool. So I'm just going to take an executive order here and change it to hard data for hard issues, how much urine, all of it. And I don't need to learn how to progress this. So this is actually more commonly known in the field for those of you who are drug researchers and ever bump into our team. It's called the P study. First, my acknowledgements to our funders, without whom this would never have happened. This was very aggressive timelines on this research, so without a very quick turnaround funder, this would not have happened. So to Good Ventures and GiveWell, and if you've never gone to them for funding before, do, they're awesome. Thank you so much for letting this happen. And then also to the Washington State Department of Corrections, we had a very unusual relationship with them that allowed us to make this research possible. Also to the Natural Science Division at Seabrook College for allowing us to use the natural science labs, which was a very big burden on that entire division. And then also to my team, Ewan Zhang, who was our lab manager, Kelly Smith managed data from thousands and thousands and thousands of records, Jonathan Kulek, who did project coordination, and to our 15 P-testers. All right, just by way of background, we know that a sizable share, if you buy the old version of the book, I know it's definitely in there, the 2012 marijuana legalization book, discusses that a sizable share of illicit drug use is consumed by people who are under some form of criminal justice supervision. So if we're thinking about what are the effects of marijuana legalization, we have to know, well, what are the states doing? What are the departments of corrections doing in terms of managing their caseloads differently? Immediately after legalization in 2012, Washington and Colorado both just maintained their policy. So even though marijuana use was allowed at the state level, they continued to prohibit the use of marijuana and continued to test for THC and sanction for any drugs tests that tested positive for THC. Colorado still prohibits marijuana use in its criminally involved population, but Washington changed its policy. Their policy took a major reform, which created this opportunity for a natural experiment around what happens when you remove the prohibition from drug use in a population that we know is heavily concentrated with heavy users. Washington Department of Corrections only oversees medium to high-risk individuals. There's lots of drug involvement, or there has been historically, and we had a population that we had a lot of data on, including P. So this is the natural experiment. And in May 23rd, 2014, the director of the Department of Corrections sent this directive to his agency. Now just remember the following. Think about basically a paramilitary organization. Well, it's the military, right? The boss sends out notification to 8,000 employees, and this is the notification. As of June 1, 2014, DOC will discontinue testing for THC. We're going to stop testing. They ordered special cups that had no strip. In other words, they would not even able to know if the person had tested positive for THC. So even though they weren't going to respond to it, they wouldn't even know about it. And not more than that, not only did they decide that they were going to no longer test for marijuana, they posted massive notices in every single field office. There's 113 of them across the state. They posted notices ahead of time, letting everybody know that June 1, THC was essentially not prohibited by the department. So flashback, that happened in, this is June 1, 2014. It's flashback to November 2013, where the state was scratching its head and trying to make a decision about whether or not they wanted to bring their marijuana policy in line with state law. And at the time, they said, okay, well, let's do what states do. We'll have a work group. So they had this massive statewide work group, and there were two priorities of that work group. The first was to try to assess, to predict what that policy reform would mean essentially for jail days. To read between the lines, what that meant is that the priority for the state at the time was cost reduction. If they removed THC from the strip line, would they save money? So that was the first thing they're looking at. The second one was, well, what do our staff think about this? They have 8,000 employees, so they did a massive survey of their staff across the state, asking what staff thought about this upcoming change. I learned about this policy and change, upcoming change, in March of 2014. That gave me about 8 weeks of knowledge that this natural experiment was about to happen to the date that they stopped testing. That's an 8-week window to find funding for what was going to become over 50,000 urine specimens. The world doesn't really work that way. For those of you who've ever submitted to NIDA, I did. I'm still waiting to hear back. It's 2016. Seriously. Establishing baseline use. I mean, only from NIDA's here, I'm sorry, but it's a true story. Establishing baseline use. The first thing we did was go into work with their folks in data, looking at their administrative records. We studied just over 100,000 specimens just before the policy change. The baseline positive there for THC, for marijuana, was about 5.5%. That was based on about 20,000 individuals. The projection at the time was that not testing for marijuana was going to save about 7% of their violated days. That means how many days somebody's not in. Violated days are the people who are put into a local jail because they've had a technical violation, and testing positive for an illegal drug at the time was a technical violation. Their projections was it would save them about 7% in jail days. They were actually surprised. They had expected a bigger bang for their buck, but only 7% of jail days were being contributed by marijuana positives. This was the feedback in the field. The field was mostly not very happy about this coming change. The DOC was prompted mostly by cost savings. The field thought this was going to be a bad idea. There was especially reservations on the eastern side of the state, which tends to skew more conservative. They were actually quite horrified about what was to come. The corrections officers felt that permitting a mind-altering substance was going to undermine the drug treatment role that the agency was serving, and thought that it would really undermine the message that they were sending to their supervision population. And the other pushback was, and we heard this over and over again, that discontinuing testing was going to increase the use of other substances, that we would see a spike in THC. We did. We'd see a big increase in THC, in marijuana use, and that going along with that marijuana use, we'd see an increase in other drugs. And in these responses, one after the other, we'd hear a specific reference to the gateway effect. The gateway effect. This is going to be a big problem for the state. So going into that, so the key policy question here was, given this reform in Washington state, will we see an increase in marijuana use? We did. And if we do see an increase in marijuana use, what is that going to mean for the use of other illicit substances in the state? So that was the key idea. So this is our study. As of the reform from June 1, 2014, the department may not, by policy, test for marijuana. They may not test for marijuana, except if marijuana is specifically prohibited at sentencing, and those are very isolated. There are very, very few of them, so we don't lose much because of that exclusion. So we requested permission from the department to let us do independent testing for THC, and we would never share the results with them. So an external evaluation group would receive their urines, and they asked us how much urine we wanted, and at the time it became very problematic to actually receive only some of it. There were two things going on. We wanted all of it because we knew we could look at subgroups, so So at this point, we were talking with our funders, and they were saying, well, how much urine are you going to collect, because there's a cost per test? And we were thinking, well, we would do some strategic sampling across the state. And then Washington said to us, you can have all of it or none of it, because by policy, it's really easy to issue a directive to ship your pee to Malibu, but we can't start cherry-picking places. It's just too complicated. So it was all or nothing. And we said all, except I didn't have any funding at the time, so it was a stressful moment about to mortgage the house. Anyway, we also didn't get any ROB approval for prisons. Well, we would have, but it would have taken us a really long time. That would have slowed us down. So all of our urine comes from the community. It's individuals who are on probation or parole under the supervision by DOC. So how much urine did we want? We want all of it. But what's so nice about having all of it is our samples are massive. So it really allows us to look at what is the portfolio mix? What is the change in the drug use profile following this important reform? So we're really glad that we had the full dump. And having a census rather than a sample is very nice. So they collect the urine at 113 field offices. We have 3 sources of data on every cup. We have the positives that are recorded by a corrections officer on top of the cup. We have the actual strip cup, and we have what is recorded in the administrative system. Every single one of our samples, yay, is geocoded, so we know exactly where it's coming from within the state. And we think that's pretty cool. All right, study goals. There were several of them. There were 5 of them. It would have been nice if we had this funded. The first was to create a repository. Did I mention that? The first was to create a repository. The second was to see what happened to the change in marijuana use. The third was what happened to the use of other drugs. We were then looking at changes in other violating behavior. Did I mention we have a whole lot of data on these people because they're supervised by a state agency? And then we were also looking to see whether this reform led to an increase in drug treatment seeking behaviors and how that changed following the reform. Project status, we have finished the first 3. We have our repository. We finished testing this Friday. This is why I look as tired as I do. We have just finished. We completed 53,000 specimens. Our loss rate was only 2%, 2% lost in shipping. Sometimes the COs didn't close the lid well enough. We had spilled urine. It did not smell good in the lab. But we finished 53,000. And after the reform, we saw a sizable increase in marijuana use. I've been warned not to share much results today, but I can tell you it was a whopping increase. Baseline was about 5.5. We had a positive test rate right by the time in the last couple of months, of about 25%. So from 5.5% to about 25%. There was quite a lot of variation in terms of where we were seeing the concentration of prevalence. And as I said, we actually have data at the city level as well as regional level, and of course all the individuals. The highest prevalence was on the southwest side, lowest prevalence up there on the northwest side. And we have quite a lot of variation by actual level at the city level. So the highest prevalence rate was 43%, lowest is at 13%, and we'll be providing the city level data to researchers once we've completed all of our analysis, so other researchers can fold this into their own data analysis. A hint of what's to come, and I know that we don't have a lot of time here, but this is what's about to come. We think this work is going to be of consequence for other states and other state drug testing policy. And this is why we have clear evidence that testing individuals on probation and parole suppresses their marijuana use. We have the use in this criminally involved population was lower than the use in the general public. Let me repeat. The use of marijuana by probationers and parolees was lower than the use in the general public because they were being tested regularly and they were being responded to and sanctioned for their use. So there was an artificial suppression in marijuana use for this population. But testing also changes the drug use mix of the portfolio. So let's consider the following. Most criminal justice agencies do not respond by type of drug. If you test positive, you get something happen to you. And it doesn't tend to matter which drug if you're on supervision. If it's a technical, you're going to get a sanction no matter what drug it is that you're testing positive for. For regular marijuana users, you can test positive for up to 30 days after any particular experience of use. For methamphetamine and opiates, it sticks around your system for about 3 to 4 days. So if you're under criminal justice supervision and you're a probationer or a parolee and you want to beat the test, you do the math. I'm not going to say anything because I'm not allowed to report results today. Our paper will show exactly what happens to the case mix once you remove THC from testing, and things move in directions that are very much in line with the other sorts of research we've heard today. The only difference is we have hard data and 53,000 specimens, which adds to the research literature nicely. One more thing, I think we also have to be a little cautious about our analysis, and that's why there has to be a lot of more geeky work to follow before we actually submit on this paper. There have been several other important reforms in Washington state. Policy analysis is never easy, so when we're quick to run with a golden ticket solution or a quick answer to a difficult question, it means we're kind of bluffing because there's so many other things going on. We have hard data and it tells a phenomenal story. The results are so interesting. But life is complicated. Washington state wasn't sitting in a laboratory vacuum while we waited for all this testing to happen. They passed several other major policy reforms that could also have influenced the findings that we see. But we absolutely do see very compelling trends following the reform that they undertook. Just a quick pitch, and this goes in line with the fact that I really would have liked some NIDA funding for this, is that we really do need nimble research. The policy issues here are so important, and the research funding hasn't caught up to the aggressive timelines that we need to inform decision makers. If we're going to need if we want good policy, we need good research, and timelines of 18 months waiting to hear back from an agency just isn't okay. Pitch for nimble research.
So, I did have one question for you, Angela. Do you have, it sounds like you don't have the data yet about what the impact is on other drug use, or you do have the data. Can you say anything about what you...
I think I inferred pretty strongly, and that's all I could do at this point.
Okay.
Sorry.
Understood. All right. Lastly, we will hear from June Kim.
So I'm really happy that I'm following these two presenters because I think my presentation follows very nicely. Dr. Pacula had mentioned the 2014 study, the state-level study that suggested that these medical marijuana laws reduced opiate overdoses. So what I did here was try to investigate the mechanisms, like Dr. Pacula did, but in in a different way. So no conflicts of interest. So in 1996, California passed the Compassionate Use Act, which provided criminal protections for patients and defined caregivers who could cultivate marijuana that physicians can now recommend. And following that, there's been 22, now 23 other states and the District of Columbia that have also passed medical marijuana laws. So who is eligible? In most states, patients with severe or chronic pain indications can receive medical marijuana as treatment. And in the US, chronic pain affects a lot of people, and it also has a high societal cost. However, some states are more medicalized and restrictive, and they don't allow for severe chronic pain. So the most common treatment for this type of pain in the US has been the use of prescription opioids. However, there's very little evidence of the long-term efficacy of such use, and the growth in prescription opioids has closely corresponded with the growth in opiate overdoses that we've seen. So is there a better recommendation? In the absence of a treatment alternative, supply controls like PDMP have been suggested that they might have been driving the recent uptick in heroin use and overdose. Marijuana may play a role in meeting these treatment needs. What do medical marijuana patients look like? They're typically on the younger side, and most report using marijuana to relieve pain. These are just from surveys of patients coming into medical dispensaries. And most report using marijuana as a substitute for prescription drugs. So are people actually substituting? Again, evidence from the state level has suggested so. The Bach-Huber study I mentioned, and also Dr. Pacula's work that she just presented on. But the evidence from the individual level has been a little mixed. Wen also looked at the NISDU, but she used like a binary, he or she used a binary MML variable. Dr. Pacula looked at dispensaries. So while Wen found no change, Pacula found a slight decrease. But again, the survey questions only assess non-medical use. Dr. Pacula also mentioned the ARCOS data in that study, and again, that is also a state-level study. I've been told that there are skeptics here. I was among one of them. So I wanted to look at the individual level. So broadly, on the left, if these laws are actually reducing opiate overdoses, we would expect that they would also reduce opiate use. And that's what this study plans to do. So how can we assess this? While the prevalence of opiate use can be difficult to measure, as in self-reported opiate use, opiate positivity in the blood or urine is objective, and it provides an indicator of any use, non-medical, recreational, it's just use. While we know of no representative population data with opiate positivity among living participants, well, I guess we have the criminal justice participants, but they're not population representative. One potential data source lies in the toxicological testing of deceased drivers. So this study is not assessing whether opiates increase crash risk. We're just looking at samples of deceased drivers that crashed in states before law and comparing them to similar samples that crashed in states after a law. So that's my study question. And because so many of these studies that have assessed medical marijuana laws have found varying effects for age, we stratified by age. So the data comes from the FARS, which is it's an annual census of all crashes that result in a fatality that occur on a U.S. public road. We only included drivers that died within 1 hour of crashing to avoid false positives. And not all states test the majority of their drivers. So like if we looked at a state that only tested 20% of their deceased drivers, we're probably getting a very biased sample, as they're probably only testing people that appear intoxicated. That's how they tested the blood in their urine, and the FARS records drugs in the following priority order, with narcotics being the first. The main outcome of our study was the odds of just being positive for opioids. Our MML, our medical marijuana variable, was based on operational status. We defined that as allowances for home cultivation or an active dispensary. We did this because, as Dr. Pacula mentioned, there's tremendous heterogeneity in these state laws, and we wanted to have like a consistent effect. Is it? We also added an additional indicator in some of our models for whether the state had ever passed a law. This was to avoid making like an apples and oranges comparison. We wanted to compare driver states, or we wanted to compare states that have passed laws with states that will eventually pass a law. So we don't want to compare like California and Texas. We're trying to compare California and New Mexico or Colorado. So these are the 18 states that tested the majority of their drivers. You can see the effective date and then what we defined as the operational date. 5 states had passed laws, 3 of them in our study period, but they did not, when the law was passed, there was no option for home cultivation, and the dispensaries that were planned to provide the medical marijuana hadn't even opened, so we didn't consider them operational. This is just what the drivers look like. They're grouped by whether they crashed in a state that had an active law, whether they crashed in a state before an active law would eventually be implemented, or if they crashed in a state that never had such a law. As you can see, they're pretty comparable along age and sex. There's slight differences in alcohol involvement and PDMP characteristics of the state, but we controlled for these in our analyses. So in our first set of analyses, we just took all the drivers and we made a before-after comparison. So we're comparing drivers that crashed in the before states with drivers crashing in the after states. Drivers crashing in the never states are just used to kind of set the temporal trend in opiate use. We used a multi-level logistic regression with a random intercept for state of crash, fixed effect for year, and all individual and state level covariates. We also used the fixed effect for state, and we found the same results. We also added interaction terms between our MML variable and also our EverPass variable with age to test whether the effect of these laws varied by age. This is just kind of what the data looks like. In red are the before states, green are the after states, the open circles are the never states, and it's just the prevalence of opiate positivity by year. This doesn't really tell us a lot, but it's nice to look at. So overall, we found a slight but non-significant reduction in opiate use. That's across all ages. When we tested for the interaction, it was significant, so we report age stratified estimates. And we find that for younger drivers, under 20 and under, no effect. Drivers over 40, no effect. But for drivers 21 to 40, we find a significant reduction in opiate use. We also looked at state-specific effects. And with this, we're just comparing within the same state before and after changes. And to do this, we need before and after data, and we only had such data on 4 states. We used the difference in difference method that contrasts the within state change with the change in a group of controls, assuming that the pre-intervention trend is similar. which allows us to kind of difference out any sources of bias, measured or not. So to select our controls, we used all eligible states within each 6-year period that tested the majority of the drivers in that 6-year period. And also, they had to be in states that did not have a law at that time. And then we also did the same thing, but only included the states that had ever passed a law. So these are the 4 states we looked at. This is just a mnemonic of what difference in difference is. It shows P increasing, but P might have increased anyway, so we take the trend from Q and difference that out. This is Colorado compared to the group of controls. What we did was we combined the 3 years prior with the 3 years post. So in Colorado, they had 687 drivers that died within an hour of crashing in the 3 years prior to their law. 1.75% tested positive for opiates. After the law, it was 2.17 for an increase of 0.42. Among our controls, we observed an increase of 1.1. And so you get a crude difference in difference of a 0.7 reduction. Adjusted, it's 0.2. But if you look at the numbers, they're fairly small, so all these results are actually not significant, but they all tend to show the same thing, all the reduction. So among 21 to 40-year-olds, deceased drivers, crashing in state years with an operational medical marijuana law was associated with half the odds of testing positive for opiates compared to similarly aged drivers crashing in state years before an eventual law is implemented. However, this association wasn't observed for other age groups. This might not be surprising, as most states have age restrictions on who is eligible for medical marijuana, and most surveys show that most medical marijuana patients tend to be younger. Some limitations. I'm going to skip to the second one first. We're only analyzing a subset of states, so our results might not be generalizable to all the U.S. Further, they might not be generalizable to the entire public. They potentially might only be generalizable to like drivers. The first limitation, we can't infer causation. We're assuming that the reduction in opiate prevalence that we observed can't be explained by other factors like increased highway safety enforcement after a law is passed, or by differential selection into the study, like if opiate-exposed drivers are less willing to drive in states with these laws. But if you look, the numbers of deceased drivers is pretty consistent for the before and after periods. So this, while it can't rule out these alternative explanations, it makes us feel a little more comfortable. So the advantages, we use an objective measure of drug use. We have individual level data, and we performed a bunch of sensitivity analysis. I showed you the state-specific effects. We also assessed this among non-culpable drivers, so drivers that shouldn't have had any responsibility in the accident. In theory, they're kind of randomly selected. We found the same thing, we had much smaller numbers. And we also did the same thing where we took out one state at a time and reran the analysis, and we received consistent results throughout. So just to bring it home, if these laws are actually reducing opiate use, as our results suggest, it just lends support to the hypothesis that these laws are actually protective for opiate overdoses. And it's been consistent throughout all the different ways we've looked at it. So just some discussion. There was a comment in the Wen paper. She said the effect of MML implementation on marijuana abuse dependence constitutes a potential public health concern similar to that of the prescription drug abuse epidemic. I disagree with that. I think we would rather have one than the other, but that's just me. How do we weigh the potential harms of increased marijuana use at the population level with the potential benefits? And what is the most socially responsible way to implement these laws? Should we allow for home cultivation? Should we have the state-sponsored dispensaries? Who would benefit from the implementation of these laws? Should it be the government through taxes? Should it be private entities? Or should it be patients? And what impact will marijuana legalization have on medical marijuana laws and any benefits they confer? I know in Washington State, when they legalized marijuana, they had to create an entire infrastructure for recreational marijuana. They had to set up all these shops. And in Colorado, what they did was they just flipped the signs. In Washington, they had to build this entire system that was competing with medical marijuana. And so the state ended up just hacking away at the medical marijuana law, and patients lost a lot of rights. So that's just one thing to consider as you go. And that's it. Thank you.